Welcome, everybody, to Workshop 23, Enhancing Care Improvements for the Changing CF Landscape. I'm one of the moderators, Ambika Shenoy. I'm a pediatric pulmonologist and Associate CF Center Director at Children's Hospital of Philadelphia. And my co-moderator is Dana Albin, who's an Associate Professor at the University of Virginia. We have no disclosures related to these presentations, but we will be covering some common and less common cystic fibrosis manifestations that impact long-term care as people with CF grow and age. We'll be identifying some innovative processes that address care across institutions that positively impact health outcomes for all people with CF in all age groups. And we'll also identify some additional outcomes beyond lung function and nutrition that can affect health and quality of life from childhood to seniors with CF. So I'd like to start by inviting our first presenter, Dr. Carolyn Robinson. She's the Associate CF Center Director at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. So Dr. Robinson, please come and join us. We're excited to hear your talk.
Thank you for having me. This is the conference disclaimer. I have nothing to disclose. So I would like to talk about implementing a sustainable process to improve short stature identification and endocrine referrals in a pediatric cystic fibrosis clinic. Just to give you a little bit of background, so I'm with Johns Hopkins All Children's Hospital Cystic Fibrosis Center. We are a 265-bed hospital in West Central Florida. We have 161 patients with cystic fibrosis. As you can see here, the hospital is located in St. Petersburg, but we also see cystic fibrosis patients in both Sarasota and in Tampa. We do have a large endocrinology group associated with our hospital, and they see patients in both St. Petersburg and in Tampa. So once upon a time back in 2023, we were looking at our program-specific report, and we saw that our institution was very low on our patients' height. So as we know, a lot of patients with cystic fibrosis are generally shorter than the national average, but we found that our patients were even shorter than those with cystic fibrosis. And you can see in the bottom that it was a really consistent problem over the last decade. So we did some background research to see, is this really a problem or something that we should, just note for our patient population? But we did find that in research it is associated with decreased lung function and increased morbidity. Important to this session, we find that patients who have short stature as kids do not catch up by adulthood. So they continue to be short into adulthood. The problem begins very early in life, and studies on human growth hormone can see that it does help in patients gain height. Additionally, it may be overlooked because we may be focusing on weight in our patients and BMI. Additionally, we may be focusing on nutrition to encourage increase in healthy fats, as well as knowing that increasing their protein intake is really important for height gain. We also had a specific patient example that in 2019, you can see here that this patient with cystic fibrosis was quite lower than his mid-parental height and then had a significant decline in his height. He was referred to endocrine at our institution, and we found that with the start of growth hormone, he had a significant sustained height even after coming off of growth hormone. So our first step was, are we underestimating our patients? Maybe they're higher than we're actually measuring. So we developed a way to see if we were obtaining heights correctly. So we developed a standardized way to measure height. And then we did find that most of the heights we obtained were accurate. So then we developed a diver diagram. We had a couple of things that we were noticing. So we found different referral practices to endocrine from different providers within our CF group. And then we found that there was concern that when we sent them to endocrine, the endocrinologists were treating them differently across the different endocrine providers. So not only with short stature, but with some of our other endocrine-related disorders. So we developed a global aim. So we aim to create a CF endocrine multidisciplinary clinic. So the process begins with identifying patients with endocrine disorders. The process ends with an established algorithm that successfully identifies and refers patients in need of endocrine evaluation and treatment. By working on this clinic, we will establish a robust multidisciplinary CF endocrine clinic. And it is important to work on this now because we have patients with really complex care needs. So we developed different specific aims. The ones on short stature was those meeting 3 of the 5 criteria for short stature, then referred to CF endocrine clinic. So we measured 5 different things: mid-parental height, growth velocity, bone age, patients less than 3 standard deviations below the mean for height, and then identifying puberty onset. So we first decided, kind of easy thing to do mid-parental heights. So we found that mid-parental heights were not being recorded in EPIC. So those checking in our patients collected parental heights at clinic visits, and then we continue to do this at all new patients who are coming into our center. So we obtained mid-parental heights on 98% of our cystic fibrosis clinic. And then we went on a new PDSA cycle on referral to endocrine. So as I stated, we had referral practices that were inconsistent between different providers. So we developed 5 parameters for short stature. So below mid-parental height, growth velocity less than 5 centimeters per year, height more than 3 standard deviations below the mean, and then bone age greater than 2 standard deviations below expected, and were they having precocious puberty. So we discovered problems, and we developed new PDSA cycles to deal with those problems. So the first unanticipated problem, so we are CF clinicians as pulmonologists and really are not very appropriate to assess puberty. So we then excluded puberty as a criteria, and then redefined if they were 3 of 4 positive, then they would be referred to endocrine, and then limited them to age 2 to 14. Our second unanticipated problem is that we had no patients greater than 3 standard deviations below the mean. So then we looked back into CF literature suggesting that greater than 2 standard deviations below the mean, equating to height less than the 3rd percentile for age, would be appropriate criteria. So we changed to that. And then we found that bone age is not really a recommended procedure for patients with cystic fibrosis. So our cystic fibrosis population did not have documented bone age. So then we redefined the criteria. If they had 2 to 3, then we would obtain a bone age. So our results, we screened 159 patients. 155 had mid-parental heights documented. Those we could not were due to a decease in a parent or the patient being adopted. 46 were found to be below. All of the patients had their growth velocity assessed, and 13 were found to be below. And then 159 were assessed to have a standard deviation below the mean. So we had 5 of those patients. So 7 met 2 of the 3 criteria, and then 2 met all 3 criteria. So those with the all 3 criteria were referred for a bone age. The patients had bone age. They were assessed by endocrinology in our multidisciplinary clinic, and 2 of them were started on bone age. So you can see here with the diagram the different population of patients. So these are the 2 patients that were referred for short stature. They were started on growth hormone, and they are starting to have an improvement in their velocity of height. You can see on the first patient why we were first initially concerned about the height measurements. As you can see, there's quite a bit of an outlier of their height measurement. So this is the 2024 program-specific report. You can see we've made a slight improvement. We're still below, so we're continuing to work on this QI project to even improve our numbers. So Sustainable practices, we do now have a multidisciplinary CF endocrine clinic. We also have a dedicated endocrine provider in our Tampa clinic that works hand in hand with our CF endocrine clinic. We have a standardized measurement of height. All new patients are asked for their parental heights. We have incorporated the standardized screening with a focus on the height velocity for referral to endocrine. We're still working with endocrine hand in hand on their expertise of the bone age. Potential confounders, where we're too late. So a lot of our population is a little bit older. So if we had started on this earlier, would we see an improvement? Should we broaden our scope for referrals? So instead of 2 out of 3, even if it's just one measurement lower, should we refer them to endocrine CF clinic? Patient priorities. So as I'll go into, we also are seeing these patients in endocrine for other disorders, and so they're screened as well for short stature. We have some have been offered growth hormone, and with the management of their CF, they don't want to start doing daily injections. And then additionally, mid-parental heights. So as I said, only 46 were below their mid-parental height. So just in general, we might have a shorter population. We have also gotten bone ages on some patients, and it's already been fused. So again, that's going to be too late for an improvement of growth hormone. So in conclusion, this QI approach demonstrated feasibility, improved clinical consistency, and led to actionable treatment decisions, including initiation of growth hormone therapy. This method holds promise for a consistent endocrine referral process outlined for other CF clinics. And then we are using similar strategies for our multidisciplinary endocrine clinic. One is with CF-related diabetes, so instituting more continuous glucose monitoring. There have been concerns in the past with our CF population that they wouldn't return the monitor. And then we've also made some changes to our oral glucose tolerance testing. So previously we were doing 0 and 2 hours with the concern of an extra stick, but we've been really finding more abnormal glucose levels at the 1 hour level. So that's been instituted. And then also just facilitating care for patients. So our patients will sometimes respond to our calls as compared to the endocrine clinic's calls. So we've been able to facilitate kind of that joint practice model. Additionally, another endocrine disease that we're looking at is vitamin D deficiency. So we found there was a lot of variance of the provider on the vitamin D dosing. So that's been more in line. That also gets screened by our multidisciplinary endocrine clinic, as well as we have some patients referred for vitamin D deficiency. Thank you to our team, and then thank you to our endocrinology colleagues and our institution for allowing for this multidisciplinary clinic. And then these are my references. And then I stand available for any questions.
Thank you so much for that excellent presentation, Dr. Robinson. If anybody has questions, please come up to the microphone, and you can certainly message questions using the app as well. Dr. Powers.
Portland. Great presentation, great quality improvement, really learning on the fly. As a clinician doing this for a long time, I also had clinical thoughts. You showed us the height data. What was the BMI data for your center? Was that below the 50th percentile? We always think about BMI before we.
Yeah. Well, our previous, one of our previous quality improvement projects was we had very short or very, very low weight babies. So we had made some significant improvement in our baby's weight. And then after that, we went to the stature. I think our BMI is probably about average.
Correlating with that, like what is your height of your 0 to 2 year olds? So we're always thinking about stunted baby, right? So
yeah,
at that age.
I think our 0 to 2 is pretty short as well. Yeah.
That's interesting.
Yeah.
Just a general question I thought of. I don't know if anyone knows the answer. Is the rate of growth hormone deficiency different in CF compared to the general population? I have no clue. Is there anyone? Is there, does anyone know if is the data suggesting there's a higher rate of growth hormone deficiency versus the general population? Or do we know?
I don't.
Anyway, thank you. Very good.
Thank you.
While others are thinking of questions, I have a question about partnership as well. Have you and your group thought about including input from primary care providers of younger children as well? And if they have growth concerns that align with what you're noticing in CF clinic, or opportunities to get input from them as far as puberty or...
Yeah, I don't, we have a quite big catchment area. So we're trying to work, with the new guidelines. We're also trying to make sure all of our patients have primary care providers, but we haven't necessarily received feedback from them or anything.
I also have a question. Do you happen to know what type of studies endocrine team obtained in clinic in these patients?
So for the ones that started on growth hormone, so our endocrinologist is here in the audience, but I know we did like pituitary studies, MRIs, and then genetic type lab type studies. I don't know if you...
And then there is a question from the audience. Someone asked, go ahead.
How do you standardize your height measurement? If you're having less people doing the heights, digital data.
Yeah, so we have digital stadiometers, and then we also kind of, because it's the 3 different locations, so we had kind of an internal check to make sure that they're all same in the 3 different locations. And then we have them measured twice, and then we compare it to the previous one to make sure that it's not shorter and it doesn't seem to be out of sync with what you would expect a growth height to be.
And then there are 2 related questions from the audience. One is, how did you get endocrine to join your clinic? And then the other one, what was the process for consolidating different endocrinologists to agree on treatment strategies?
So I think answering the second question first is that now we have one endocrinologist, as well as, when they're not available, we have another one who is monitored by the head of endocrinology to make sure everything is centered, as well as we only have one provider in the Tampa clinic that works hand in hand with the one endocrine provider. So I think, consolidating to really just using one that has more expertise in CF care. And then it was a really big push through the organization to develop a multidisciplinary endocrine clinic. So I think it was really, feedback from the higher, the C-suite people.
Hi, excellent presentation. I don't really have a question, just a comment. I wanted to tell you that you've done a wonderful job with this. People often think that measuring height and weight and things like that and doing projects on these measures is low-hanging fruit, and it's not. It's like the highest hanging fruit. So just well done.
Well, especially, trying to get lengths in 2-year-olds is, yes.
Hard adults.
Yeah, our adults always kind of lose height.
Yeah. We like to wear, heavy, hair.
Yeah. You would think it's so easy, but it's not.
Yeah.
All right.
Thank you so much for your
Thank you.
talk.
I would like to invite Dr. Bailey to come and present. Dr. Bailey is a senior dietitian in Melbourne, Australia, and she's a very dear friend of mine. So welcome her.
Thank you. All right. Hello, everyone. Can you hear me okay? Excellent. I'm here to talk to you today about enhancing our CF clinic care delivery in Melbourne, Australia. So this is the disclaimer. These are my disclosures unrelated to this talk. And I wanted to start off by speaking a little bit about the institution I'm working for. I'm at Alfred Health, and this is in Melbourne, Victoria, Australia. We're a large public teaching hospital, meaning we're a government-funded hospital. We have a big catchment area, so we pull patients from all over the state of Victoria, as well as multiple other states in Australia. And our Cystic Fibrosis Center serves over 330 patients. So we're a decent-sized adult center, and we have a multidisciplinary specialty team. And it's very similar in makeup to any US or European teams. So like many CF care centers globally, we found that our outpatient care model was struggling with keeping up with changing care needs, particularly in the setting of most people having access to highly effective modulator therapy. This happened a few years later in Australia. We have had broad access to ETI for about the past 3 years, as opposed to 6 for most places here. So this is a screen grab from some of our registry data from Alfred Health specifically, and this shows that our hospitalization rate was declining, similar to what's happening other places. We're really shifting away from acuity into an outpatient model of care, but this is creating a lot of complexity. So we surveyed our patients to sort of understand what their main concerns were. And we found that 25% of them said that their wait time in clinic was the worst part of coming to our center. And then we also found that they were requesting better access to the multidisciplinary team and that they wanted more patient-centered approaches in the outpatient setting. And we also found that we had an average wait time of 31 minutes per clinic session, meaning that that was the total time the person spent with downtime in clinic waiting. So either waiting to be in the room, waiting for providers to come in, and that was about 27% of their clinic time was spent waiting. So both patients and staff had a lot to say about the wait times and our clinical inefficiencies. You can see from the quotes here that patients and staff were sort of saying the same things, just from a different perspective. And in Australia, we still have emerging national QI learning health networks and systems with CF care. So our challenge in this project was really to create a structure for improvement using entirely local resources that could maintain its sustainability. And I think this is kind of the eternal problem in quality improvement as well. So we really wanted to reshape our care model and make sure that we were doing something that benefited the patients and the staff as well. And we wanted to use a really systematic framework with quality improvement to make sure that we were doing this in a data-driven way and keep our consumer voice at the center of it. So what emerged out of all of this was a collaborative pre-visit planning tool. And I can see in the audience that there are people here who work with the CFLN or have been in the CFLN, so you're very familiar with what pre-visit planning is. So for our aims, globally, we wanted to improve the wait time, and we also wanted to create a product that would be our pre-visit planning tool and then enhance the uptake of this tool. So our SMART aims were by the end of the first quarter of the project, we wanted to reduce the clinic wait time by 25%, which would have been roughly 9 minutes. And we also wanted to increase the uptake and use of the collaborative pre-visit planning tool from 0%, because this was a new process for us, to 25% by the end of quarter one. We also wanted to collect some balancing measures, and we chose missed multidisciplinary team visits. This means if a multidisciplinary team member from allied health or nursing wanted to see the patient, but they weren't able to connect and complete that visit, we wanted to capture how much that was happening. And we also wanted to capture clinical touch points, meaning how many clinicians saw the patient per clinic encounter. For our methodology, we used the model for improvement, which everyone is probably very familiar with. And we also used design thinking, which is a methodology that was a little new to me. And this really focuses on using patient voice and empathizing with patients in order to create a product and a prototype and then test it systematically. So we also wanted to identify our delay drivers and things that were creating the inefficiencies. We used process mapping for this, as well as cause and effect diagrams. And then we also wanted to map the clinician and the patient journey in clinic. So we created an electronic journey board. And many people might already be using one of these. Your electronic medical record might have one embedded. Being in a public health system with a slow EMR uptake, we just used Microsoft Excel and Teams. So we've made an Excel sheet that essentially tracks the times that the patient check in, when the clinicians go in and out of the rooms, and we've put it in Teams, which is our health system approved way of communicating with one another, so everyone can view it in real time. We also have a column on here to put patient responses to pre-visit planning so that everyone on the team is aware of the patient's goal or agenda. We worked with our patient and family partners to develop this pre-visit planning tool. We had 3 consumer partners who were really our co-leads in this project, and they led the design of the tool and then looked to us to build it out in REDCap. And then we ran iterative PDSA cycles on the tool to get broader patient and family partner feedback and make sure that we had it as right as we could for everyone. And for data monitoring and analysis, we use time series charts and control charts. So for our root cause analysis, I mentioned that we had done a cause and effect diagram. I won't go through this in detail, but we did get together as a broad multidisciplinary team, including our consumer partners, to have everyone give input on what they thought was driving our inefficiencies. And then we took a team vote based on impact and effort on what was driving everything and what we thought would be most realistic to intervene on. And the team selected the absence of pre-visit planning, both with the patients and in general, as one of our major intervention areas. It's worth noting our team meetings that we had each week with our multidisciplinary team were mainly focused on inpatient because we had been a predominantly inpatient program. And we're just shifting to focus on outpatient, and we're primarily doing retrospective rather than prospective planning discussions. And there was no patient voice coming into that either. Patients had also given us ad hoc feedback that they didn't know who they were going to see at a clinic visit. They might see everyone, they might see only the physician, and they just kind of wanted to be prepared for what was coming, which is fair enough. So I've mentioned for our interventions, we created the electronic journey board, which is really more of a tracking tool, but I guess doubled as an intervention. We also held multiple design sessions with our patient family partners to develop the pre-visit planning tool. We implemented a prospective multidisciplinary team meeting where we brought the pre-visit planning responses in, as well as had the disciplines identify which patients they wanted to see and how much time they thought they might spend with them, so we could sort of pre-plan our clinic flow. Then we did our iterative PDSA testing of the pre-visit planning tool, and eventually we implemented very brief clinic huddles so that anyone who might have missed the larger team meeting could have a look at the journey board and know what it was that the patients wanted that day. And then eventually we rolled our prospective multidisciplinary meeting into our existing team meeting. And that was great because it eliminated a meeting and it made us more efficient on our end. No one needs extra meetings, right? This is a quick look at our PDSA ramp for the pre-visit planning. We started by piloting with 3 patients. We then expanded it to an entire clinic and then to 2 clinics. And then eventually we expanded it to all 5 of our CF clinics. But we were able to scale this up really quickly over the span of about 5 weeks. So for our results on wait times, I've pictured the first quarter here of when we implemented things, and I've noted when we started our prospective multidisciplinary team meeting and also when we began using pre-visit planning in all of our clinics. And you can see on this first chart that we had a sort of immediate drop after the prospective MDT was introduced, but then we had this trend here once we began using pre-visit planning in all of the clinics with a consistent reduction. And this gave us the impression that we had actually made a systems difference with our interventions, and this wasn't just noise. So we were able to shave 10 minutes off of our wait time, took it down to 21 minutes, which was a 32% reduction in that first quarter. This is just another time series chart that looks to the next 2 quarters that we were doing this project. We wanted to continue tracking data for a while to make sure our change was sustainable, and we were able to maintain the median wait time around 21 minutes for the following 6 months after the project implementation. So we have early sustainability. I thought it would be important to break out the telehealth versus in-person clinic appointments. Alfred Health does a higher percentage of telehealth than any adult center in Australia because we have such a large catchment area and some patients travel from places they have to fly in from. So we are doing about 70% of our appointments as telehealth since COVID. And we had a suspicion that the face-to-face appointments were taking longer and also that they involved more clinicians seeing the patients. And we were correct when we broke this data out into in-person on the left and telehealth on the right. We found that the telehealth visits had shorter waits, but fewer clinical touch points and a much higher rate of missed discipline visits per week. So in the telehealth appointments, there's an average of 9 missed discipline visits per week as opposed to 3 in the face-to-face appointments. We also had about 5 clinical touch points in the face-to-face appointments and only 2 in telehealth. So that would kind of make sense why it's easier to have a more efficient visit if you're seeing less people. But this did highlight the need to preserve multidisciplinary access and made us happy that we were collecting that balancing measure. So this is a control chart of 1 year of the project, looking at our pre-visit planning response rate from June of 2024 to June of 2025. Over these first 4 time periods, we had expanded the pre-visit planning to all clinics, and we fairly quickly in Q1 reached a response rate of about 24%. And then when we look out a year, we have maintained that mean of 24%. And we don't have any astronomical data points on here. Also, we don't really have any trends. This kind of indicates we've got some common cause variation, and we were pretty stable at 24% response rate across time, even though we've got that sawtooth measure. And I also wanted to highlight the people that our patients were requesting to see in their clinic appointments when they did respond to the pre-visit planning. So we had 659 requests to see either allied health or nursing across the project year, which demonstrated that our patients do still want to see the rest of the team, even though sometimes they don't see us as often. And the majority of our patients had requested to see the physiotherapist and the dietitian, about 30% of each. The pharmacist had requested about 16%, and nursing at 13%. Our psychosocial team, psychology and social worker, were substantially lower, but this is likely because our mental health team does visits asynchronous to our multidisciplinary clinic, so they can have more time with the patients and more privacy. They keep their own schedule. So this looks kind of crazy, but we weren't surprised because of the way our clinic runs. So quickly, I'll go through just some barriers that we encountered and the solutions we came up with, because this is always the most important part of quality improvement projects to me. We had some low physician attendance and uptake of our prospective multidisciplinary team meeting. I think it's always hard for busy people to add another meeting into their calendar. So we ended up condensing those meetings into a meeting that everyone already attended and had been blocked in their calendars for many years. And it sort of forced us to become more efficient, but that's not a bad thing. We also had consumer feedback ad hoc along the way, in addition to feedback from our 3 main consumer partners. And they had identified that clinicians weren't necessarily addressing what they filled out on the pre-visit planner, which was not great. So we wanted to make sure that we had a tracking document that was highly visible to everyone, and that we did those pre-clinic huddles so that if someone forgot to look at the pre-clinic tracking document for whatever reason, we could bring it to their attention right at the start of clinic. One other thing to highlight is that we were working in a limited QI infrastructure. And so we used low cost tools like Microsoft Excel and Teams and our existing staff champions to roll this out. So in conclusion, co-design really does drive sustainable improvement. And I think that the greatest strength of this project was working hand in hand with our patients and actually letting them lead the design of this tool, because it was something that had better uptake for that reason. And in that way, patient partnership supports system evolution. Telehealth is often praised for making appointments easier and less burdensome to people. But I think there is also the side of it where we have some new challenges where people might log off before they can see other members of the team. And so it highlighted to us that we have to be mindful of how to provide high quality multidisciplinary care, even in the telehealth setting. And using these quality improvement frameworks systematically really allowed us to scale this up very quickly and to accelerate the adoption of our project. So for next steps, we are conducting a patient education campaign that's more comprehensive. The response rate being at 25%, while that's above industry standard for most surveys, it still feels low to a lot of us. So we are trying to do more education with our patients to improve the response rate. We are also planning strategies for higher completion of multidisciplinary care team visits in the telehealth setting and trying to come up with protocols for when patients only need the physician versus when they need the whole team over telehealth. And I think similar to most CF centers, we're probably going to be looking at our no-show rate because since everyone's feeling better, they're voting with their feet and don't want to see us as often. So I just wanted to say a quick thank you to my team at Alfred Health, both the clinical team and the research team, with a special acknowledgement of Felicity Finlayson, our nurse consultant, who was my co-lead in this project, our center director, Dr. Peter Walk, and Rob Sterling, who was instrumental in the methodology and implementation of this project, as well as all of our patients and their families, because I'm pretty sure every single one of our patients has participated in this at some point in time and wouldn't have been possible without them. And I'll take your questions.
I have a question. Dr. Bailey, that was a great example of how the multidisciplinary team can lead a program or a process together. I have some logistical questions. You mentioned that the main barrier for people seeing multiple specialties is that they log off. I have a similar experience with our telehealth clinics. Have you thought about any type of interventions you can design? And then my second question is related to reimbursement. How is telehealth reimbursement in Australia? We're getting some struggles here in the United States with reimbursement, especially for subspecialties.
Sure. No, those are both great questions. And while patients were logging off sometimes, we found after speaking with them more that they didn't know they needed to see some of us. And they were like, oh, we would have stayed on had we have known. Or perhaps our clinic coordinator let them go, or whoever was completing their appointment ended it. So sort of multiple barriers there. So we have started putting in the chat box what our clinic coordinator calls her spa menu, which is sort of a link to the pre-visit planner and sort of a summary of who all's requested to see the patient that day. And so that way, if someone does have a meeting and they weren't anticipating to see us, they won't, at least we know, and we can sort of readjust our time. Your second question was about reimbursement for telehealth. It's not something I think about very much because it's a very different healthcare system. To my knowledge, it's not reimbursed or billed out differently, but we are in a universal healthcare type system, and Medicare does cover the telehealth appointments in the same way it covers the face-to-face. No allied health or nursing bills separately to the physician either. Just very different. Hi, Mike.
Hey, Juliana. Great seeing you.
Good to see you too.
I love the slide on barriers and solutions, right? I love that. And so I took a photo of them. Okay, what can we do in our team? So, right, learn and learn. We've done a lot on clinic flow and satisfaction. What struck me was your care team, right? They were dissatisfied with clinic. I'm sorry. And so the wait times, seems like clinicians are waiting to see a patient. And how is that addressed with your team, the flow of who sees who? Is it consistent? Historically, talking to different teams, physicians sometimes hog the time, right? And they're in there for 2 hours and then there's no time for the rest of the team. So are they being held accountable and you having good handoff? Is the patient waiting between providers or waiting to get into a room? So how are you addressing that?
Yeah, so it's good to hear it's a universal problem. Clinic flow has kind of been an issue everywhere I've worked as well. And every system and every clinic is so different. We found the majority of the wait time was not rooming the patients. It was the patients just sitting in the room waiting between providers. People also kind of all showed up all at once rather than having like a tiered scheduling system. So that's been talked about as like another intervention, is going back to having multiple tiers. We don't have a particular order that we go in. I know some clinics have done it that way. Having that journey board that was visible to everybody, it really like empowered the whole team to be able to like to be accountable, to know how much time they were spending, to know where other people were, where they could go next. But we do have a clinic coordinator who is sort of our person that's in charge of the chaos. And she tells us like where to go and when, and really monitors the journey board carefully. But I think having that visibility allows us all to be a little bit more self-directed and help her out when she's tied up with a phone call or speaking to a patient to close out their visit. And I think just anecdotally from her talking with us, it's made her job a lot easier and feel like there's less pressure because other people can take accountability and know when to go in and come out.
Yeah, so it's intentional, right? You have to be intentional to have clinic flow correctly, and you have to have respect for your colleagues, and that is so critical. And you won't have joy, and you won't want to go to clinic if you're not respected by your colleagues. My time is my time valued, and is my voice valued. So it's really, really important for a team approach.
Absolutely.
So, I mean, you're just starting. I can't wait till next year's abstract.
Thank you, Mike, for that reminder. It's really, really important.
Gonna beat Noah. Yeah. And of course, thanks to Mike, I'm tiptoeing now. Dr. Bailey, Mike just reminded me, I also love that problem and solution side by side. You mentioned several times patient participation is important. In fact, you used the term consumer, which is interesting. Have you shared that with your patients to show, and then like what the input that they provided that actually contributed to the solution? And what was how did you share it, and what was the reception?
Absolutely. So we've shared it via our newsletter, which I recognize doesn't get all people all the time. And we have discussed having a town hall where we can share this alongside the registry data. It's just not been scheduled yet. It'll come after our planning day as a team. And we did share this back to our consumers who were co-leads in the project, obviously. They were at all of our meetings and helped us to make these changes. But sharing out more broadly was mostly through the newsletter at this point. Excellent reminder, though. Thank you.
So just 2 comments, no questions. That was great. I was really impressed that 31 minutes was where you started, and that was thought to be too long. So the fact that you were able to reduce that was very impressive. I was just going to, for telehealth, we had run into that same problem. What we tried to do, and I think has been effective, is kind of emulate what we do in person, where we have a whiteboard with a list of patients and disciplines, and under each patient, we make a little box to show which discipline is going to see that person on a given visit. And in Teams, we've created a virtual whiteboard. And so at the beginning of clinic, we have our whiteboard, and it shows for each patient who needs to see them. And that way, whenever somebody leaves the virtual room, we say, so-and-so is going to come in next. And that way we have a running sort of tally of who needs to be seen. And it seems to work pretty well.
That's amazing. Thank you so much for that. I'm looking forward to talking to all of you after this too, to get more ideas that I can take back home. Remind me the first thing you said, because, the wait times, that's what it was that and I saw you when I was talking. We had that same reaction as a team. We were like, wow, this is actually pretty good. But the patients were very unhappy with it. So we were like, clearly this needs to be addressed. And we felt inefficiencies as staff members on our end. Like we might have been waiting for hours up there, even though they were only waiting for 31 minutes. So I think it was, both patients and clinicians were having an issue, even though that seems like a good wait time.
Thank you so much. I just want to mention, if you are interested, our team has a Teams template of that clinic tracking tool. So if you're interested, just email me, and I'm more than happy to share what we use in our clinic.
Thank you so much for that excellent presentation. Next, we have Abigail Vera. She's a nurse practitioner from the UC San Diego Health System. And she's going to be sharing her work on improving access to audiology diagnostic testing for patients at an adult cystic fibrosis program. Thank you so much.
All right. So good morning, everyone. Thank you for this opportunity to conquer my fear in public speaking. Uh, today I will be sharing our team's QI journey of improving our patients' access to audiology testing by incorporating audiology software program in our clinic. Okay, so I have nothing to disclose. So, to manage the complex manifestations of CF, people with CF often require short and or long-term courses of ototoxic medications. As a result, people with CF are at an increased risk for hearing loss and balance issues. So that's not new to us. According to the CFF care consensus guidelines, annual audiologic examinations are recommended for people with CF undergoing treatment with these types of medication. In the past, our adult program had an audiology service present and embedded within our clinic to test patients during their visits. Unfortunately, this service was terminated during the global COVID pandemic and not reestablished thereafter due to critical staffing shortage. So access to audiology services for our patients receiving these therapies have been challenging in our center, primarily due to the limited availability of diagnostic hearing appointments and the overwhelmingly high demand the audiology department is facing. So in fact, this is a nationwide problem. Right? There is unfortunately an audiology shortage, primarily due to mismatch between the rising demand, a stagnant growing supply of professionals, exacerbated by workforce burnout. Doesn't that sound familiar? And increasing prevalence of hearing loss in an aging population. So, for our target goals. So at our center, approximately 11% of our patients with CF in our program had a diagnostic hearing test done in 2024. So that's what we're working with, our baseline. And that's a significant decline from our pre-COVID metrics. Our program aimed to increase audiology testing for our patients from 11 to 30% by the end of March of this year by utilizing the audiology software during these visits. Okay. So you may be wondering and asking me, Abby, how can we improve access for our patients? What are some reasonable and fairly uncomplicated audiometer options we can possibly offer patients? So with the help and guidance from our audiology director at our facility, Dr. Erica Zettner, our medical director, as well as the partial financial support from our pulmonary service director, we decided to move forward with AMTAS. But Abby, what the heck is AMTAS, right? So as you can read up there, AMTAS stands for Automated Method for Testing Auditory Sensitivity. So just a brief background, AMTAS has been developed over the past 15 years by Dr. Robert Margolis. And this method has been validated through multiple published studies over time. AMTAS, which is designed by audiologists, is a patient-directed system using algorithms and software to perform audiograms for diagnostic or screening purposes. A good amount of you in this room may already be aware that tablet and web-based audiometry performed by non-audiologists in an outpatient setting are already being utilized in CF centers to screen for hearing loss in adults in CF. So we are just one example. And you can see some key benefits mentioned and are listed on the right side of this slide. So our increased efficiency, this test is self-paced. It requires minimal supervision, its accessibility, the reliability, which I've already mentioned, and its versatility. It's portable tablet that can be used in various settings and perfect for a clinic setting. All right, Abby, you piqued my interest. So how does it work? This software runs on a portable tablet computer with calibrated headphones. The patient responds to the sounds by pressing a button, indicating that they hear that sound and guides themselves through the test with clear on-screen instructions and brief videos. So a patient can independently complete this test with an average, give or take, 15 minutes to complete. during their visit. All right, so this is how the audiology unit looks like. It's a very simple setup. You have the calibrated headphones, the tablet, the microphone, that tiny little thing right there on the right, disposable ear covers, a stylus for them to press yes or no, and that has helped with infection control and easy cleaning of the device between patients. All right. Alrighty, so here's a glance of our process map. The beginning of December of 2024, with the help of our pharmacist, patients that were scheduled for an annual visit and or have been identified to be on ototoxic medications were offered an audiology test using this system during their clinic visit. So for patients that were agreeable to have this test completed, our nurses set up that audiology tablet and briefly reviewed with the patient directions on how to use the tablet itself. The program also has a very brief introductory video that plays for the patient prior to the testing to kind of, emphasize it more to them so they have a better idea what to expect. At the end of the visit, our nurses would review the normal results with patients and recommendations. If the patient's results were abnormal, this was escalated to our provider to review and forwarded to our audiology team for further guidance if necessary. So these referrals to the audiology department are marked urgent and are reviewed by the audiology director herself. And then all the results, audiology results, are uploaded in our EHR system and sent to patients via secure electronic communication by our administrative staff. All right. So this picture is an example of what the audiogram report would look like. It includes the patient information, the classic audiogram, as well as the legend to the right, which is the quality assessment indicators. So for example, the predicted accuracy is basically the overall quality of that test. And the different categories would be good, fair, poor. I have a normal one up there, so it's good. The false alarm rate, which is the number of times the patients responded yes when there was no sound or stimulus present, divided, of course, by the total number of times that there was no sound present as well. And then the quality check fail rate, which is the number of times the patient did not respond to a stimulus above their established threshold. So I am not an audiologist, so I do appreciate, and obviously our patients are not audiologists, so I do appreciate that the actual copy that they do receive is fairly easy to understand and interpret. So it just basically tells you right here, if you can read it on your own, hearing in your right ear and left ear is normal, and it does go in depth, not in depth, but, a comprehensive explanation of hearing loss and, the speech area and, being the normal, mild, or moderate. So patients have really appreciated getting that copy. So for our results, I'm happy to report the implementation integration of our system in our clinic increased our audiology testing to 90%. So we've had 41 eligible patients, 37 completed the testing. A lot of our patients didn't really give us pushback. They said, yeah, great, let's do it. I don't want to schedule a separate appointment like 6 months out. So, and among the 37 who have completed the test, 5 patients have had some sort of abnormal results and referred directly to the audiology department. All right, so in conclusion, so we have obviously significantly improved access for audiology testing for our patients. The system is quick and has effectively identified patients that would need additional testing. Obviously I feel it's positively impacted quality of care for our patients by removing the need for an audiology outpatient visit and just potentially reducing costs associated with that outside screening. And lastly, the collaborative relationship and partnership with the audiology team was critical for our patients, particularly with the abnormal results, to gain timely access to additional necessary testing if needed. We are still getting to know the system with all of its features with any type of technology, right? So for future steps, I think a smaller step is just improving that workflow and hopefully getting that integrated officially into our EHR system. So it's just easy upload. And if you would like to learn more, please check out our poster. I think I'm 862. So thank you for your time.
Thank you for your talk, Abby. We're happy to have any questions from the audience. And maybe while people are thinking, I'll ask, actually, I have a two-part question. First is this covered by insurance typically?
So yeah, we don't bill for this. So it's just a service that we provide for our patients. But yeah, no, nothing for billing.
And then the second is, what is the software cost? Is there any setup that a clinic would need to space, location?
As in like the unit itself, space very limited if you have a locked drawer in like a clinic. In regards to for price, you said price. Price, I'd say it's not like a capital request of like $10,000 plus. I would say a couple of thousand of dollars
Per year.
Yeah, and we got lucky, before they tightened up the purse strings, we were able to get support. So.
Great talk. Already really excited about maybe implementing this ourselves. Of those 5 patients that went to audiology, what did audiology think of them? Were they like, these are totally normal, or they did a lot of other testing?
Yeah, good question. So the majority was like totally normal, just continue to monitor. But it's just really, I'm not an audiologist, right? Our providers are not audiologists. So it was just nice to have that support and be like, okay, we'll just repeat next year just to make sure everything's okay. Yeah. And we do also have that feature to test for high tone frequencies, especially for, patients who have been on multiple courses of IV aminoglycosides or aminoglycosides. And we typically just add that for every patient that's had a history of on being on those medications.
And that leads me to my question, actually.
Oh, cool.
I wanted to ask if you made any clinical changes in your practice based on these results. We implemented a process at UVA like 5 years ago where we no longer do double coverage with aminoglycosides for Pseudomonas, specifically for this reason.
For sure, yeah.
And because of our aging population, this is a true concern that even the nebulized aminoglycosides can lead to hearing loss. So I was wondering how you approached it.
Oh, no, for sure. Actually, it has definitely led to some medication changes, simplification for medication, stopping that inhaled aminoglycoside. And then, of course, that monitoring of the sputum, and most of the time, though, we do typically take away that inhaled aminoglycoside, especially if they have not grown that particular bacteria for, years. So, but yeah.
Very good. Thank you so much.
Yeah.
Next, I would like to invite Dr. Noah Lichtin. He's an associate professor at Johns Hopkins University. He's going to talk about expanded use of remote objective monitoring during telehealth visits for people with CF experiencing acute symptoms, or in short, Europa.
Thank you. Thanks for inviting me today. I see Randy Hunt sitting here. And so before I go on, I'm going to just thank my collaborators, and particularly Randy, because he gave this update last year, and a lot of the background slides are probably Randy's. So it's a pleasure to give an update on our project called Europa. You can see the underlined letters where the acronym comes from. It's expanded use of remote objective monitoring during telehealth visits for people with CF experiencing acute symptoms. In other words, a quality improvement project to expand telehealth services for urgent visits in persons living with CF. This is the standard disclaimer. I don't have any relationships related to this presentation to disclose. And so, like many others today, I'm going to go back in time to the end of 2019, beginning of 2020, when highly effective modulator therapy was approved, and also we were heading into the COVID-19 pandemic. And clearly, COVID-19 caused some rapid changes in healthcare delivery. You can see in that top graph, going back to 2011, showing clinical encounters, cultures, PFTs, they were cruising along at a steady rate, and then all of a sudden, 2020, they dropped off dramatically with fewer clinic visits and such. Along with that, on the bottom bar graph on the right-hand side of the slide are clinic encounters showing in-person visits and telehealth. And you can see going back in time, virtually everything was in-person visits with a little bit of what they called telehealth or other encounters. And I suspect a lot of that green in the past was whatever other encounter actually was. But in 2020, all of a sudden, telehealth made up almost half of clinic visits, and it remained a significant part of care in 2021. Also, along with ETI expansion, we saw a drop in acute exacerbations, but we certainly, I think, all recognize we still see exacerbations, we still need to deal with them, and they're still certainly a major problem. So telehealth, as I said, rapidly expanded in 2020. I think by and large, a lot of patients liked it, saw some benefits to it. I think the same goes for providers and care teams. But there was a lot of variability, and I think it's continued to be a highly variable endeavor. Platforms change, reimbursement changes. I think a lot of us have seen recently with the government's shutdown messages saying, oh, you can't see Medicare patients anymore by telehealth. And so it's continuing to evolve. Some of the shortcomings of telehealth have been the lack of objective data. Obviously, you can't do physical exams readily. Whether there's objective data has been highly variable, including things like home spirometry, vital signs, respiratory cultures. And so I think a lot of us have questions about how viable is telehealth moving forward? Is this going to continue to be a large part of what we do or not? And then when it comes to sick calls, even before the COVID pandemic and highly effective modulators, how centers manage sick calls has always been a highly variable endeavor. Treatment patterns vary quite a bit. For the most part, we don't collect objective data. Some places bring people in for in-person visits quite readily, whereas others do a lot by telephone. How exacerbations are defined and how they're treated varies quite a bit, and whether there's even follow-up after these sick calls varies quite a bit. And so that sort of led to our interest in doing this project. And so our goal was to establish and optimize a protocolized evaluation and treatment for people with CF experiencing acute symptoms through telehealth with expanded remote objective monitoring. And so our specific aim 1 was to establish this protocol for urgent telehealth evaluations. And in aim 2, we wanted to optimize the uptake of the telehealth for sick visits, optimize remote monitoring, and implement a treatment algorithm. This is kind of the 1,000-foot overview of the entire project. There's probably a lot of small fonts on there, but in the upper right-hand corner is the inclusion criteria. And we really wanted to make this a broad slice of life. And so pretty much anybody with CF age 6 and older who had not had a lung transplant was eligible. We did want to enrich our population so that the patients that we enroll would be likely to have exacerbations. And so we initially tried to enroll patients who were in the top 20% of acute exacerbations in 2020 and 2021. Over time, we did find that it started to become harder and harder to enroll patients, and so we loosened those criteria as time went on. In the upper left-hand corner is just a list of some of the baseline measurements that we collect at enrollment. So we record the best FEV1 the patient has had in the previous 12 months, the number of visits they've had in 12 months, the number of courses of antibiotics they've had in the prior 12 months, and then patients record a baseline FEV1 using their home spirometer when they're in stable condition. So we've enrolled 153 patients. At the time of enrollment, patients get material to collect respiratory cultures at home and all of the remote monitoring equipment, which if you look along the bottom, they get scales, they get pulse oximeters, they get home spirometers. We're set up to administer the CF respiratory symptom diary questions. And as I mentioned, they get material for remote cultures. I'll take a step back here and just comment on the remote cultures. Not all sites have participated in the remote cultures due to various logistic reasons. And interestingly, this project is funded by the CF Foundation, which I am grateful for. One of the reviewers who had generally good things to say in their review said, you know, the sputum cultures might not be that useful. It's going to be logistically difficult. You might think about just not doing it. I think so we've got 4 sites. I think half of us have done the sputum cultures and half didn't. I think the reviewer's comment was quite prescient because it's been a challenge and I'm not sure how useful they are, but I'll talk a little bit more about that in a minute. This is a brief overview of the protocol that we developed. So we broke exacerbations down into mild, moderate, and severe, and then would implement schedule follow-up 6 weeks after within 6 weeks of their virtual visit. And we have a number of process of care measures that I will go into more detail on. So probably our key process measures are the number of acute telehealth visits that are scheduled within 48 hours, the number of visits with objective data collected, including spirometry, and our proportion that are adherent to the treatment algorithm. And so this is a little more detailed view of the protocol. Again, probably too small to really read, so you'll just have to believe what I say. But again, there are 3 categories of exacerbations: mild, moderate, and severe. Mild is on the left, so patients who have less than a 5% drop in their FEV1 from baseline, and really no or very mild increases in their CRIS score. Those are mild. And if they're considered mild, the recommendation is really to promote adherence with airway clearance, Dornase, hypertonic saline, consider inhaled antibiotics, and follow them up. The middle category is moderate exacerbations, moderate severity. That's a drop in FEV1 of 5 to 9% from their baseline, or a mild change in their CRIS score. And in that case, the emphasis was really on oral antibiotics, and again, promoting adherence with airway clearance and other medications, and again, scheduling follow-up. And then on the right-hand side are severe exacerbations, which would be considered anything with a greater than or equal to 10% drop in FEV1 from baseline, or a more significant change in CRIS score. And in that case, it was either consider oral antibiotics, but really think about IV antibiotics and or hospitalization. And so just briefly to touch on the QI processes we've followed. So each site developed key driver diagrams to focus on things such as scheduling telehealth visits, getting spirometry at the sick visits, scheduling follow-up, and we did repeated PDSA cycles to try to implement some of the things that we identified to address these various problems. And so to jump right to some of our results. So again, as I said, we've enrolled 153 patients. Some are still going through follow-up. The mean age is about 30, but we had a fairly broad range, and a little over 20% were in the pediatric age range. 65% were female, 89% were white, and we had fairly equal representation from Black and Hispanic patients. Spirometry at baseline was about 73%, but we had quite a broad range, so anything from 17% up to 127% predicted. And the CRIS score was 28.4 at baseline. And so of the 153 patients, this led to 134 sick calls so far. Not necessarily 134 distinct patients. Some patients are frequent callers. And of the 134 sick calls, it has led to 100 telehealth visits. So essentially 75% of those patients were scheduled for telehealth visits. The difference between the sick calls and who got scheduled for telehealth visits is largely either patients had symptoms that weren't consistent with a pulmonary exacerbation, like they called for GI complaints, or they had some more acute problem like hemoptysis or pneumothorax that needed prompt attention and wasn't appropriate for telehealth. We did really a great job with getting the telehealth visits scheduled in a timely manner. So 98% were scheduled within 48 hours, and 73% had spirometry collected at the time of their telehealth visit. And of the patients who we have spirometry on, the FEV1 at the time of their sick call was 63.8. So if you recall, our baseline was about 73%, went down to 63% at the time of exacerbation. And the change in their CRIS score was a little over 13 points, which is a pretty significant change in CRIS score. So of those 100 telehealth visits, 38% were considered mild, 41% were moderate, and 20% were severe. And below that, you can see how they were managed. So 62% received oral antibiotics, 11% received IV antibiotics, 10% inhaled antibiotics, and 9% were hospitalized. And of those 100 telehealth visits, 78% had follow-ups scheduled. Again, pretty good mix of severity of exacerbations. Interestingly, when if you jump down towards the bottom there, when they were mild or moderate exacerbations, the FEV1 at the time of their exacerbation was 65%. For the more severe exacerbations, FEV1 was 59%. And at the time of follow-up, FEV1 had improved overall to 68.1%. So not quite back to the baseline of 73, but at least trending in the right direction. Interestingly, when the patients were prescribed oral antibiotics, their increase in FEV1 was about 8%, whereas the group that got IV antibiotics, they had a 14% improvement in FEV1. And then we have a subjective question about whether the patients felt improved, and 60% at the time of follow-up were felt to have improved, whereas another 13% hadn't improved and were hospitalized. In 80% of telehealth visits, the Europa treatment algorithm was followed. And interestingly, when the algorithm was followed, the FEV1 improved by about 7%, whereas when the algorithm wasn't followed, the improvement in FEV1 was only 3.75. And I have to delve into that more deeply to figure out exactly what's going on there. So to conclude, follow-up is still ongoing, so we'll have more sick calls and more data. In general, the protocol for telehealth visits has been reasonably easy to adopt and adhere to. We're continuing PDSA cycles to ensure that patients are scheduled properly and that we collect spirometry and that we get follow-up scheduled properly. Broad patient I sort of hinted at this when we changed our enrollment criteria. Broad patient buy-in has been a bit of a challenge. Some patients just say, hey, I like the way things have been done all along. I don't really want to get into this protocol that may be a little more complicated. Whereas others thought, hey, that sounds like a great idea, and we're happy to do it. Pediatric pulmonary exacerbations have been relatively uncommon, which I think is a good thing and not terribly surprising. Again, data at this point are pretty limited, but the outcomes do look a little bit better when the algorithm is followed and when IV antibiotics are used. I think the response to IV antibiotics kind of fits with other studies. And what I will be interested to see is we were administering a post-study satisfaction survey to our participants. I'll be very interested to see what they think, but we don't have any data back on that yet. And I just want to recognize the other study investigators. So Peter Mogazel is my counterpart on the pediatric side at Hopkins. Gina Hong and Michael Ray at Penn have been tremendous. Carolee Forcine, Katie McKee, and Varsha Taskar at Augusta, and Randy Hunt at Emory. So thank you.
Thank you so much. This was an excellent presentation. Of course, I have some questions. So one of the questions is related to immediate follow-up in clinic. So I know you scheduled the follow-up in clinic in 6 weeks, but we know from previous data that some of the telehealth visits actually transfer or transform into an immediate in-person visit, or at least a PFT in the office. So did you look at the data? Did you collect the data to see how many of the telehealth visits end up being actually an in-person visit?
It's a good question. We do have the data. I haven't looked at it yet. The 6 weeks, we wanted to be fairly broad in terms of how follow-up was done. We said within 6 weeks. And so certainly a lot of them fell within 2 weeks, and a lot of them were in person as opposed to telehealth. But for the protocol, we kind of said some sort of either telehealth or in-person follow-up within 6 weeks. But yeah, we'll have the data, just haven't looked at it.
Hi, thank you. That was a great presentation. My name is Vic, Dr. Joe Hall from Mary Bridge Children's in Tacoma. My question is related to your PFTs and how were you able to obtain these PFTs? Sometimes there's a lot of barriers with kids being far and getting them in a timely manner. And I also noted there was 27% who didn't receive the PFTs. And if you found that impactful, and how much effort would you kind of put in to try to get everyone to have PFTs?
Yeah. So my initial interest in the project was an interest in doing home spirometry. And I think what we found during telehealth visits during COVID is that if we just gave out spirometers and told patients use them, we got almost no information. And what we were able to do was have a respiratory therapist jump onto the telehealth visit, talk the patient through the spirometry, and in those cases, we got great data and spirometry almost every time. For this project, it was more open to how each site did it. But again, it was at the time of the telehealth visit, we would say, get your spirometer, blow into it, tell me what it says. And so I think that generally works. Obviously, there's going to be some variability, and some of the telehealth visits were like, oh, I'm at work, I don't have my spirometer with me, and so that's why there's, only I think it was 78% had spirometry.
I have a small follow-up. I can imagine the most important part is the RT teaching of the patient. And do you think some countries in Europe have started this, but do you think there'd be any role in mobile spirometry labs to go to these patients' house, get cultures, PFTs?
Yeah, I think it's a wonderful idea. I don't know who's going to fork out the money to make that a reality, but
it sounds good.
Hi, it's Amy from Lenox Hill Hospital, New York. I have kind of a similar question. We're finding a lot of our patients now have lost their PFT, and I can't find ways to get them reimbursed by insurance companies. So I don't know how to address that issue in obtaining PFT data.
Yeah, that's a real problem. So all of our patients essentially got spirometers during COVID. When we enrolled them in Europa, we said, oh, do you still have your spirometer? A lot of them did, and that was great, but through the grant to do this project, we purchased more spirometers and gave them out. But you're right, it is a problem moving forward. You can charge for reading home spirometry, and we've avoided that, but I guess that's a potential way to try to make it feasible. But yeah, it's hard.
We use our center grant to buy some spirometers every year, and we replace some of the spirometers that are lost. There is a Mir Spiro 1 that is approximately $110, so it's a lot more affordable than the ones that the foundation distributed. Those were like $500, so something to consider.
Thank you so much for a great talk and really interesting work. I think we are learning a lot about, how to best use and optimize remote monitoring in this post-pandemic period. My name is Jacqueline Davis. I'm from Boston. We also are interested in home spirometry and remote monitoring. My question about the Europa study is twofold. One is, do you have data on people who were triaged into that mild exacerbation category, not given orals, and then kind of failure of that and needing to either take oral antibiotics or be hospitalized? And two, I'm curious how the different sites set up a structure that they had virtual visits available within 48 hours of any call that's coming in during business hours.
Okay, so the first one is easy. So for the mild exacerbations, we will have data on what exactly they received and did they, what happened on follow-up. Unfortunately, I have not looked at that yet. In terms of how did each site make it work that we could have telehealth available. So part of it, we only targeted enrolling about 20% of our clinic population in this because we realized it was just not going to be feasible to try to do everybody. So we kind of carved out a reasonable number of patients. For my site, I just kind of said, I'll do them and fit it in and make it work. I don't know, Randy and Michael are here. They can
There's like
comment on what they've done.
Per site who was like on call for it, or
ESA cycles, honestly, where we tried to make it go through our scheduling service and a nightmare. And better or worse, it just came down to just like Noah, I was like, just call me, and I skipped everything else, and I would send the patient a direct email with our Zoom link and time.
Yeah,
Yes, we worked with our scheduling team and our nurse practitioner, and then Gina and I would either have set carved out times that we could do it, or at least with the flexibility of telemedicine not needing a clinic space, would often just schedule off our typical schedules, but our schedulers would help us do that and then send a reminder to collect the data, which we then often needed to do on the visit anyway. But it was our nurse practitioner who had frankly just started, so had a fair amount of openings, and then us.
Yeah, our original plans, there's 5 physicians in our CF group, and each week one of us is responsible for sort of acute problems. And so our original plan was whoever was on that week would do it. It just wound up being easier for the most part for me just to say, if I'm around, I'll fit it in. But you're right, it brings up questions about kind of what's feasible moving ahead.
Thank you.
I don't think I'd want to be the one always doing it.
Carolyn with Johns Hopkins Children's Hospital. Either anecdotally or kind of in the future, did you have patients who, for example, had temperature monitoring and at home, COVID, RSV, flu monitoring? Because, obviously that would be...
I actually just sort of left it out of the slides, but yes, we also gave patients COVID kits and asked patients to record temperature. So I think with COVID rates sort of fluctuating and the tests not being that sensitive, it's hard to know how useful that was. Our nurses, when the patients would call, are pretty good about asking whether you've tested for COVID and sort of trying to triage things.
Wow, that being on call 24/7 is very impressive.
Wow. Most of the time the calls didn't come in after hours, so it was...
Okay,
Yeah,
but
could use
still
work.
every single day for telehealth, very impressive.
Thank you so much.
No, we'll ask you next year how you're able to sustain this.
I'm his partner and I feel bad, so now I'm going to help.
So at this time, I'd like to ask Katie Poach, who's a senior laboratory researcher at National Jewish Health, to join us and present her team's work on reaching a new milestone, the need to screen for menopause in women with CF. Thank you.
Yes, it's still morning. So good morning. I am Katie Poach, and I'll be presenting our QI team's project. I have nothing to disclose. So just before starting, I just want to say that while I'll be using the words female and woman throughout this presentation, our QI team does acknowledge that menopause may affect those of various gender identities, and no exclusion or disregard is intended. Menopause is having a moment. Everywhere you look, there are headlines on the topic. It's on the covers of magazines and above the fold in newspapers. It's in our social media feeds with influencers and celebrities talking about their experiences and how we do not care. And it's the topic of best-selling books and our book club reading selections. But it's not just in mainstream media. The Lancet dedicated a 2024 issue to a 4-part series about menopause with the hope to bring forth a new approach to support and empower women transitioning into the next stage of their life. There are North American and international menopause societies. In fact, the International Menopause Society celebrated the 15th annual World Menopause Day just this last weekend. And the NIH supports research on women's health through its Office of Research on Women's Health. And their centralized resource, Discover Women's Health Research, highlights the NIH-wide efforts to close the gaps in women's health across the lifespan. Now, before I go too much further, I want to make sure we're all on the same page and define menopause and perimenopause because the terms are often used interchangeably. Menopause is a normal condition involving the permanent end of a woman's menstrual cycle due to the cessation of the production of reproductive hormones from the ovaries for at least 12 consecutive months. It is a diagnosis that is made retrospectively because menopause is a single day, which is 12 months from a woman's final menstrual cycle. Perimenopause is the transitional period of time up to that final period and the 12 months after it, when hormonal, physical, and emotional changes often occur. So I'm a very visual person, so I adapted this image from a WHO report on research in menopause in the 90s and the stages of reproductive aging workshop. As you can see, the time between a woman's first period or menarche and her last or menopause is a variable amount of time lasting on average about 40 years from the teen years into a woman's 40s or 50s. And unlike her first period, a woman won't necessarily know she's had her last period until a year has passed without having one. Perimenopause, or the menopausal transition, is when changes in menstrual cycles often occur, including there's increases in your follicle-stimulating hormones, they can be detected, and other symptoms start to appear. These symptoms of perimenopause are often hormonal, physical, and emotional. They can include hot flashes and night sweats, problems sleeping or feeling overly tired, feelings of sadness or anger, brain fog, trouble concentrating, or muscle, or joint pain. Okay. However, if these sound familiar, these are often commonly reported in people with CF, regardless of age or sex. They're often the first signs of an infection or the side effects to a new medication. Now, what about CF and menopause? This is a relatively new topic, as women with CF reaching the age of menopause wasn't a possibility for so long. There is a general lack of knowledge about sexual and reproductive health for all people with CF. Most of the current knowledge on menopause is based in the non-CF population. However, through the CF Foundation Sharing Working Group and studies like Parenthood and Mayflowers, that is slowly changing. The few existing studies that do exist show that women with CF are likely going to start perimenopause earlier than their non-CF counterparts by about 5 years or in their mid to late 40s, likely due to the role of CFTR and female sex hormones. And what is known is that women with CF have a significantly higher rate of exacerbation and worse survival rates. The reason, however, is not fully understood. It's suggested that, again, female sex hormones, especially estrogen, may be the cause and affect respiratory health and worsen inflammation and infection for females with CF. And the importance of addressing these challenges was illustrated in a James Lind Alliance priority setting partnership out of the UK earlier this year, where among other topics such as cardiovascular health and cancer screenings, the lack of knowledge and support for new symptoms such as menopause was highlighted. And this importance of looking at the aging CF population couldn't have come at a better time. As we know, and the general age of CF population is living longer, that total adult population is growing. In last year's patient registry report, it was highlighted that there are over 3,000 people with CF 50 years or older. And then thanks to the registry team who supplied me with some of this data, you can see how the total adult population has grown over the last decade, reaching almost 21,000 people in 2024. And within that same time frame, while small, the proportion of women with CF between the ages of 40 to 59 has also grown. In 2016, those women were accounted for about 8.6% of the population. In 2024, it's at 11%, or over 2,200 women. So our team was approached by one of our CF physicians asking about a new project in December of 2024. And she asked, on the faculty call today, we talked about a standard approach to screening our female patients over the age of 40 for perimenopause and menopause, and then referring them to a specialist covered by their insurance. You think it should be a QI project, or should we just pick a screener and start doing it? And I, as the QI team co-lead, obviously this needed to be a QI project. But to see if this topic was something we could manage, we needed to examine a few areas first. So a fishbone is one of our QI team's favorite ways to examine a new topic. If you're unfamiliar with a fishbone, it's basically a brainstorming session that takes place on sticky notes. And as you work on it, you start to see a pattern and are able to group the notes into appropriate categories along the bones of a fish. And then for this project, we could group it into staffing, acceptance, the screener, patients, time, documentation, follow-up, and kind of a catch-all everything else. And with these groupings, we can now focus on the areas that we as a QI team could control and come up with an aim for our project. So the aim of this project is to assess the occurrence of perimenopause, menopause, and its associated symptoms in women with CF through improved screening practices. But how are we going to do that? So we worked first on developing some methods. Does our patient population need this intervention? What method should we use to screen? And then how should a screener be embedded into our clinic processes? So we first asked ourselves, do we have enough female patients to make this project worthwhile and to move forward with some of the other areas? At our center, we are currently split 56 to 44% female to male, with 387 females listed on our patient registry. And then when we started examining and breaking down those age brackets a little bit more in January, 94 or 26.3% were in that menopausal sweet spot of the ages of 40 to 59. And I would just like to say that those numbers have shifted slightly since we originally pulled them. So while they still account for about a quarter of our female population, as of October 1st, women over the age of 40 are now the majority, accounting for 52% of all females and almost a third of our total population. So we have enough women to move forward. The next step was to examine what method we should use. And a lit search brought forth a list of 12 potential menopausal measurements, but luckily we were able to quickly reduce that list to the 3 that you see here. The green climacteric scale, the menopause specific quality of life questionnaire, and the menopause rating scale. All 3 are validated and ask about similar symptoms, though they vary in length and detail of those symptoms. Other screening tools, such as a hot flush rating scale by Hunter and the Women's Health Questionnaire by Hilditch, They were reviewed, but quickly ruled out for either being too specific, like asking only about hot flashes or after hormone replacement therapies, or were too broad and were asking about overall women's wellness. Finally, how should we bring a menopause screener into an already busy clinic visit? So we developed 3 PDSA cycles to test this method. First, if a woman within the targeted range came to clinic, she was getting a screener, regardless of who gave it to her. Second, we narrowed it down to see if the flow would be better if it was done in conjunction with other annual assessments, like those done by the social worker or the dietitian, tasking them to ask the patient to complete it. And then third, would utilizing our recently hired endocrine-specific medical assistant as the main point of contact be best? So our results, we're going to start with the what. So our QI team answered the screeners, regardless of our age, just to assess the time it takes to administer it, because in a full clinic, every second counts. The menopause rating scale, the MRS, has 11 questions with 5 answer options. The green climacteric scale is 21 questions with 4 answer options. And then the menopause-specific quality of life questionnaire is 29 line items where you first answer a yes or no question, and then if you answer yes, you have 7 answer options. So that yellow line you see is the average time it took our QI team to read and respond to the screeners. The MRS was selected based on its length, its reliability, its accuracy, and input from our non-QI team care members. It provides an overall quality of life score from 3 subscale scores, where the higher the total score, the worse the symptoms and presumed quality of life. And then next was the how. After initiating this project, but prior to starting the surveys, our endocrinologist was brought on full time and an endospecific MA was hired. With this first PDSA cycle, we were pretty gung-ho about it, giving us a screener whenever a woman came in, regardless of who administered it. But tracking was a challenge. Not everyone administering it was fully informed on our project, and it really ended up just causing more confusion in the end. The second PDSA cycle, where the MRS was given at the same time as those other annual assessments, made for a lot of assessments for the patient without warning. Not every woman seen was due for an annual assessment, and there was some lagging interest from the staff or the patients had other health concerns at that visit that they wanted addressed. When we were able to utilize the endocrine-specific MA after her onboarding, we started to rebound from that second PDSA cycle. However, again, not all of the women in our target population needed to be seen by endo that visit. And the MA was new, and so she was still working on kind of building those relationships to bring this kind of questionnaire to these patients. And then in August, she left for other opportunities. So finally, the who. In the 6 months that we've been administering the screener, 24 have been collected. The women age and range from 40 to 57 with that average age of 46 and a half. The scores from those women who completed it range also from 1 to 26 with a median score of 12. That orange line you see is at 11, which is the cutoff between asymptomatic and mild moderate symptoms of menopause. 13 women were in this mild to moderate range, or more than half of those that were screened. No one passed into the severe range, which is a score of 36 or higher. So what's next? So we're working on developing another PDSA cycle to better implement the screener into clinic now that the endo MA is gone and the other 2 cycles we tested weren't sustainable or fully effective. And then we're also working on a better process to inform our endocrinologists and other members of the care team on the elevated scores to ensure that our patients are getting the appropriate referrals. We're lucky to have an established relationship with the high-risk OBGYN that has taken care of many of our pregnant females that we hope to be able to utilize more for menopause in the future. So it's amazing to hear the increasing life expectancy every year when the registry report comes out. However, there's a lot of uncertainty that comes with that. Little is known about the lived experience of an older CF population, and especially little is known about women during and after the menopausal transition or how menopause may affect their health outcomes. Gathering their experiences and tapping into community feedback would really support this movement going forward. And then finally, we just need to continue research on sexual and reproductive health across all of life stages. So with that, I would like to thank our QI team, Dr. Jennifer Taylor-Kauser, and the women at our center who completed yet another QI questionnaire for us during their clinic visit.
Hi, I'm Shaylee Rajput from Kaiser. I'm permanente in Portland, Oregon. This was a great presentation, so topical right now. I have a couple of questions, at least from an anecdotal standpoint. I know it's kind of in your next steps. Did any of your patients actually see high-risk OB yet? Have they been offered HRT? And do we know what effect HRT is having on lung function pre and post initiation? I know it's hard enough.
The last part I will
general
not
population
answer.
to get it.
Not a pulmonologist, endocrinologist, any of those things. But I will say that some of the women were on hormone replacement therapy.
Mm-hmm.
Some of them have been initiated on it and were not necessarily part of this survey. And I have heard through clinic conversations that the women that have started it have felt effects and benefits right away. So that's really promising moving forward. But I don't know long-term effects on it. I see Dr. Taylor moving forward, so maybe she has more insight on that.
Thank you.
But yeah, so it is part of that whole conversation to be looking at.
Hi, I'm Christina from the Spokane Center. I was wondering if the clinic was the first to initiate the conversation about perimenopause or menopause with patients, or if they had already previously discussed and been screened by their primary care providers.
So unfortunately at our center, like I feel many, they don't necessarily have a PCP. And so that is definitely part of a larger conversation that needs to be had. And so some of them are hearing about it because with the younger age range that it is with CF, and not necessarily knowing when those symptoms are going to start, we are probably starting that, or the physicians are probably starting that conversation earlier than if they were to go to a PCP or maybe even their gynecologist. And especially if they had seen the high-risk gynecologist for pregnancy, this is like that next stage that some of them hadn't gotten to yet.
Yeah, that's a great question. And I think that most people are not being asked. It's just something that wasn't being discussed, and not just in CF clinic, but in primary care. And it also depends a lot on who your provider is, which is part of the reason I went to Katie, because I was afraid that there would be some providers who would be more than happy to distribute the screener and others that would be a lot more reluctant because they didn't want to talk about it, just to be frank. To answer the question earlier about whether or not HRT is bad for lung function, we did publish a small study that showed, I mean, it was about contraception, but there were women in it who had been menopausal, and we showed that it did not actually adversely affect their lung function. But Sandy Suffian, Beth's sister, Sandy is actually putting in a CRA plus to study that question specifically.
I noticed one of the arms on your fishbone was acceptance. I'm curious what women's response to receiving the questionnaire was, and the steps to introduce that to them, as well as follow up.
Right. So that acceptance bone was both provider, like Dr. Taylor-Kauser just mentioned, and then also patient. So it was just an overall acceptance of bringing up the topic of menopause in a CF pulmonary clinic. They brought it up. Luckily, we have a fabulous team that has really established relationships. We are the adult clinic. If they're getting this menopause screener, we've likely been seeing them for 20 or 30 years. We know them. That was the issue that we ran into, though, with our MA, who had not built this relationship up and was all of a sudden giving that. And she did get shut down a few times. Like, I'm not answering these questions for you. I don't know you. This is a conversation that I would like to have someone who is more invested in my care. But we were able to then, you know, if our nurse coordinator went in and gave it to them, it was done in 30 seconds. So, yeah, so it is the acceptance of kind of both sides of who's willing to do it and how they're going to answer it.
Great, thank you. Actually, mine was pretty similar to that. I wanted to get a little feel for the like qualitative side of how did the people feel about it. Also, what was your process like? The MAs were giving the survey, but then what did the process for reviewing it and talking to the patients and kind of closing the loop look like? And what sort of qualitative response did you get from them?
Yeah, so on the back end, I mean, as you saw in the graph, I mean, half were above into that asymptomatic, or were below the line in the asymptomatic range. So it was more like just tracking. We have it now as part of, like, the hope is to have it be part of our annual assessment so that we have their scores from this year. When they're another year old or next year, we can see if there's been changes in that score. The follow-up is always done with relaying that information to their primary CF physician and then the endocrinologist. Our endocrinologist is great, but very focused on CFRD. So having that like bridge of, we know you're here for CFRD and that's because that affects the majority. We're not just at this very small population that is being affected by menopause, but that sometimes for our patients, that's their first contact with someone who would know about menopause is our clinic endocrinologist.
So I have a question too. That was an excellent presentation, and I'm not going to say anything personal, but it kind of becomes very personal. The question for you, and maybe for the audience too, is at our institution we have actually a women's clinic with specialists in menopause. Have you explored sending your patients there, and how many of you know if your institutions have that available?
That is not available at our center. We can refer, I'm assuming, right? We can refer out, which is why when Dr. Taylor came to us and she's like, we need to be able to make those referrals. National Jewish Health is respiratory, slowly getting into some cardiac. Women's Health is not part of that. But there is a network that luckily our providers are able to tap into that they know.
Well, thank you so much. Thank you, everyone. I hope you enjoyed the session from looking at short stature to menopause.